Good morning. Our presentation is going to be over local anesthetic systemic toxicity. Local anesthetic systemic toxicity, also known as LAST, occurs when high volume concentrations of local anesthetics are absorbed into systemic circulation. LAST can occur due to local anesthetic overdose, inadvertent intravascular injection, or large volume local anesthetic injection for nerve blocks. Rapid absorption of local anesthetics causes depression of voltage-gated sodium, potassium, and calcium channels in the central nervous and cardiac systems. Inhibitory neurons are blocked first, meaning excitatory neurons are no longer inhibited, and the overexcitation causes the visual disturbances, muscular twitching, and seizures associated with LAST. In the heart, local anesthetics also block the cardiac ion channels, leading to decreased contractility and bradycardia. Bupivacaine is the most cardiotoxic local anesthetic commonly used in regional anesthesia. An increasing number of reported LAST cases are occurring outside of the traditional hospital setting. Local anesthetics and regional anesthesia is commonly being used in outpatient procedures, obstetrics, and pain clinics, meaning LAST is a risk for many of our patients. The table to the right demonstrates procedures that commonly result in LAST. The most common cause of LAST was penile circumcision, accounting for 23% of all cases reported in this review. 17% of LAST cases reported were caused by local infiltration analgesia, such as a surgeon numbing the incision site during surgery. These top two causes of LAST account for 40% of all the LAST cases in this review, and neither were caused by anesthesia providers. Nonetheless, anesthesia plays a large role in the prevention, identification, and treatment of LAST, so it is imperative that we have a strong knowledge on the topic. We will discuss max doses, risk factors, identification, and treatment of LAST in the following slides.
Here is a chart that displays toxic doses of local anesthetics. Feel free to pause the video and screenshot this for clinical use. Common local anesthetics max doses that may be beneficial to commit to memory are bupivacaine of 2.5 milligrams per kilogram with a max total dose of 175 milligrams. Bupivacaine plus epinephrine is 3 milligrams per kilogram with a max dose of 200 milligrams. Ropivacaine has a max dose of 3 milligrams per kilogram and a total max dose of 200 milligrams. Lidocaine is 4.5 milligrams per kilogram with a max total dose of 300 milligrams.
Local anesthetic system toxicity can manifest with progressive signs. Initially, patients reflect local effects like numbness and tingling. However, as the plasma concentration of the local anesthetic increases, the signs and symptoms advance dangerously. We may see things like CNS agitation, starting with excitation, but eventually shifting to depression. So, for example, we would see seizures that would eventually lead to coma. And this would be followed by respiratory and cardiovascular decline. Recognition is extremely important for prompt and efficient treatment. Early identification can improve patient outcomes and prevent progression to severe complications.
LAST is not only challenging to diagnose in the early stages, as symptoms may vary among individuals, but even in the later stages it can overlap with other conditions. For example, LAST can mimic events such as anaphylaxis or procedural complications. This is why it's important to consider differential diagnoses when forming your management plan, especially in the event of cardiac arrest.
So how do we treat LAST? Hypoxia and acidosis will worsen the symptoms of LAST. Therefore, the first step is to manage the patient's airway by administering 100% FiO2. If the patient is actively seizing, treat with a benzodiazepine. You can also use a low dose of succinylcholine or a non-depolarizer. ACLS should be followed if cardiac arrest occurs with a few modifications. This includes using a dose of less than 1 microgram per kilogram of epi, as it may reduce the effectiveness of lipid emulsion therapy. If dysrhythmias occur, amiodarone is the best choice. 20% lipid emulsion therapy should begin at the first sign of LAST. It is important to note that propofol is not an appropriate substitution. Lastly, if the previous therapy was unsuccessful, the patient needs to be prepared for cardiopulmonary bypass. The dosing for lipid emulsion therapy varies based on patient weight. If the patient is over 70 kilograms, you first bolus 100 milliliters over 2 to 3 minutes, followed by an infusion of 250 milliliters over 15 to 20 minutes. A patient under 70 kilograms will receive a bolus of 1.5 milliliters per kilogram of lean body weight over 2 to 3 minutes, followed by an infusion of 0.25 milliliters per kilogram per minute. If the patient remains unstable, you may repeat the bolus and/or double the infusion with a max dose of 12 milliliters per kilogram. You need to continue the infusion at least 15 minutes after the patient is cardiac stable.
A topic that might be overlooked when treating someone with LAST is the medications that should be avoided. First, propofol is not a substitute for lipid emulsion treatment, and if someone with LAST is experiencing cardiovascular compromise, it should not be used in large doses. It is possible that someone with LAST could cardiac arrest. Often in this situation, our go-to medication is epinephrine, but epinephrine can impact lipid emulsion therapy and should be used in small doses in LAST patients, so doses less than 1 microgram per kilogram. Also, vasopressin will be avoided. It will cause vasoconstriction and increased afterload, which makes it harder for the heart to contract against the added pressure. We should also avoid any other local anesthetics that might be used for resuscitation or arrhythmias because we are trying to manage a local anesthetic toxicity. Finally, we want to avoid calcium channel blockers and beta blockers if possible because they just impair cardiac contractility and function.